All right. Thank you all for being here tonight. This is a topic that is a hot topic in MS, so I thought I would talk about it some tonight. I would like to say before I start that talking about stem cell takes a very long time. There are many questions that people have, and it's a very complicated topic. So this lecture isn't intended to address everything about stem cell. It's put together to give you a background of where we are in stem cell, what's the rationale for stem cell in multiple sclerosis, and where we're going. So we will save questions for after the talk, and I'll answer as many questions as I can. But once again, this is basically the ABCs of stem cell therapy. So here's our outline for tonight. I'm going to explain a little bit about what stem cell is, how transplant is conducted, and what's the data behind the headlines that you see all the time, and then those interested in stem cell, what questions you should ask, and where we're moving forward. So what exactly are stem cells? Well, stem cells really form the foundation of all the organs in your body. They are cells that very immature and can grow into whatever organ we want them to grow into if they have the right signal. And that's important. They have to have the right signal. They start off immature and they're not specialized. They are not destined to be liver, lung, brain until they get the right signal. So depending on where they come from, then they go into the organ that they then differentiate into. There are different kind of stem cells and they come from different places. So I'm going to just focus on the ones that we are concentrating on in MS right now. So what I have listed here really isn't a whole list of potential stem cells that can be used, but what we have data on in MS is what I'm going to talk about. So hematopoietic stem cell, mesenchymal stem cell, and a little bit about embryonic stem cells. Those are the two main ones I'm going to focus on is hematopoietic and mesenchymal stem cell. So hematopoietic stem cell, HSC, they're usually most stem cells come from the bone marrow, but start in the bone marrow, and they are destined to become blood cells. So red blood cells, white blood cells, platelets, lymphocytes. So those immune cells, they are destined to become white blood cells. They do not become solid organs. They do not become liver cells or kidney cells or brain cells. Mainly their lineage from there is blood cells. And using them in MS is basically to reset the immune system. And I will go into that a little bit later in a few slides to come. And then the second type of stem cell that we have data in MS right now is mesenchymal stem cell. These also come from the bone marrow, and these are destined to become, they can become organs, so skin cells or fat cells, usually adipose tissue cell. We can get mesenchymal stem cells from them. These are a little bit more mature than the hematopoietic stem cell. And basically what we have seen used for them in is they help decrease the immune response and enhance repair of damaged cells and help to protect nerves. All right, so the two things that we're looking at, they both have different lineage and they're destined to go to different types of cells. So our approach to how we do transplant with these kind of stem cells will also be different. What is important to recognize is you have to do the transplant or plan your treatment according to what the cell lineage is. So for an example, I'm talking about MS right now, but if you're looking for liver transplant or something, you're not going to use hematopoietic stem cell or renal transplant because they are destined to become blood cells, right? They cannot become solid organ cells, whereas you will look more towards the mesenchymal stem cell for something that has organ in it, and you can kind of direct them to become those kind of cells. All right, so hematopoietic stem cell transplantation. So how is that done? Once again, I'm going to go through the basics, not in depth because we are not in immunology class here. We're MS group, right? But for MS, the intended use for hematopoietic stem cell is for immune regeneration after you have ablated your old immune system. So after you get rid of those faulty cells or faulty immune cells that are causing the damage, the hematopoietic stem cell is there to help regenerate to get you new immune cells. And it's not for neural repair. And that is important because MS damages the myelin. And repairing the myelin is very difficult to do in the normal immune system. So this kind of cell is not for neural repair because remember in the last slide I said these normally go to blood cells. They do not go to organs. They do not make organ cells. So it's not for neural repair. It's to help regenerate, bring back new immune cells after you have taken away the old faulty immune system. So in a way we are resetting or rebooting the immune system. Okay, so what happens in this kind of transplantation, chemotherapy is given to remove all those harmful cells, and then we put back the hematopoietic stem cell, and then it gives us a new type of stem cell found in your bone marrow. Okay, so let's delve down a little bit more into it. Three steps, and let me not say basics, but 3 steps are important in this kind of transplantation. First, you have to collect the cells. Okay, the cells reside in your bone marrow. You can either collect it by doing a bone marrow biopsy. Going there is a big needle, long needle that has to go through the flesh into the bone and into the marrow, and they aspirate that. And yeah, that can be a little painful. Yeah, and one thing that can happen with that is that the amount of these cells in the bone marrow, very small amount for probably this big syringe that we're taking out. So you will have to collect a whole lot to get a good amount of stem cell in what we're taking out of the bone marrow. So the easiest way to do it is that they give you an infusion to stimulate the cells, and the cells come out of your bone marrow and gets into your blood, and we take the blood out and then isolate those cells. So the first step in this, we don't want to do a bone marrow biopsy, so we give stimulating factors, as we call it, stimulated, and it replicates those cells, and they come out into the blood, and then we take the blood and then process those cells. Those cells have to be processed. They have to separate and take out the actual stem cell that we want, and then process so that when we do implant it, remember we have to keep that it goes to the cell that we want it to be. Well, with each step in this process, you have a potential for something to go wrong, right? As much as we all have good intentions, every action, there's an equal and opposite reaction. So what can go wrong in this step of collecting those cells that we want to get? So I talk about how it's painful to go in the bone marrow and aspirate a whole lot of cells to get just the right amount of cells that we want. But sometimes people do have reaction to the stimulating factor that we give. So that's one challenge that can occur. And then the second challenge is if it's not done in a manner that's sterilized, there's a potential for contamination with bacteria, with viruses, and other things that can cause infection. So this is one area where the sterilization also come into place. So that is the first step for a hematopoietic stem cell. Then the second thing is after we have removed what we want from the blood, we have processed it, it's frozen until it's ready to use. The second step, we give chemotherapy to get rid of all the old and faulty immune cell that we have. And I put high or low dose chemotherapy here because initially high dose was what we need, what was used specifically. And you know, when you use high dose, you can see great results in patients, but we know once again for every action there's an equal and opposite reaction. You have more side effects, a more adverse reaction with a higher dose of chemotherapy. So this is one place where research is going. What is the right dose of chemotherapy to use when we are using this type of transplant for our patients? And so the right dose with minimal safety risk is what we want. So chemotherapy is given and we eliminate all those old and malfunctioning immune cells. That's the second step. What could go wrong when you're doing this step of the transplantation? This is where patients are very vulnerable because we give the chemotherapy, wipe out all your immune system. What happens when that occurs? You have nothing left to protect you from bacteria and viruses. So the risk of infection to the patients during this time period, the risk of infection is very high, and that's where patients need to be very careful. Sometimes they're even in the hospital the entire time before they go and get reintroduced, so they are not contaminated because they don't have the immune system to fight off any type of infection that can occur. So after the immune system is ablated, then they go back to the cells that they have isolated and they have processed and said this is what we want to do, and they reintroduce it into the body, and this can even can be done by IV. So all those cells that are treated is given back, and that's when it is there to kind of regenerate or reset the immune system for new immune cells to come about. And this can go up to a month for all this regeneration to occur. What can happen during this phase of transplantation is that there's the potential that all the faulty immune cells may not have been taken up during the processing, and some of them can be reintroduced back into the system. And when that occurs, then you still have some of the old things that you wanted to go to get rid of. So that's another thing that can occur as well. So 3 steps for a hematopoietic stem cell. You have to get the cells that you want, ideally through the bloodstream after you have mobilized them from the bone marrow, process them, get rid of the old immune system by giving chemotherapy, and then reintroducing those processed cells back into the body to help give the patient the immune system back. Thereby, you have completely reset and rebooted the immune system. All right, so that's hematopoietic stem cell. So the second kind of stem cell that transplant that have been studied and is being studied in MS is mesenchymal stem cell therapy. So these cells are the process is similar to hematopoietic stem cell, except that there's no destruction of the immune cell. All right, so the cells are, once again, the blood is blood or whatever part. Remember, I said these cells can be found skin or adipose tissue. You can get the cells from them. you have to take it out of these tissues. Once again, it's a very small amount in the tissue, and those cells have to be stimulated to produce more of them to get the right cell to put back into the body. So the cells have to be multiplied, because what you have when you go and do that aspirate, or when you go and do the adipose tissue, is a very small amount that is not sufficient to do what you need it to do. And then after that, after it's multiplied, it's reintroduced into the body, and it can be either by IV. Some people have tried putting it into the CSF space. Remember when you're doing a lumbar puncture, but introducing cells that way. All right. So 3 steps as well, but there's no destruction of the immune cell. That could be a pro, because the challenge with the destruction of the immune cell is infection, right? So if you're not destroying it, then the risk of infection is lower. But challenges do come with this kind of cell transplant. The right amount of cells to infuse, we haven't really gotten a hand on it. Okay, so everybody has a different protocol, and all the protocols haven't matched out, and the studies are also small right now. 20 patients, 10 patients, 5 patients, that we really don't have a idea right now what is the right amount of cell to infuse. And then what is the route of administration? Okay, I said that these cells they're a little bit more mature, so they are not like hematopoietic stem cell, where they're less mature and can go into various things. If you're a little bit more mature, your potential for growing into new type of cells are limited. So when you're given these cells, you have the problem of, are they going to mature into the cell that I want them to mature into, or are they just going to sit where I just put them? And that is important, because you don't want cells just sitting somewhere and not being mobilized or going throughout the body. Then you also have complications of unwanted cells in places that they should not be. All right. And once again, they're a little bit more mature. So what is their lifespan? I'm going to go through the studies that we have so far, and we have people who have been stable after a certain kind of stem cell therapy for 5, for 7, for 10 years. With this kind of therapy, will it be less? Are you just giving them a jolt, and then you have to do multiple transplantation? So lots of questions to be answered with this one. We have more data on the hematopoietic stem cell than we do on the mesenchymal, but it's an up-and-coming way, because we're always looking for new methods, safety, ease of use, tolerability. All of that comes into play when we are determining what's best for the patients. All right, so I give you the 2 processes of hematopoietic stem cell and mesenchymal stem cell. Now let's look at the science behind them. But before we do that, we see all the headlines, right? Oh, we found a cure for MS, you know, the latest miracle that can occur. This is what is going to cure MS. And when you see this, you say, oh, something new has come up. I want to try this, or what is the question? But we have to look beyond the headlines. That's why I tell my patients, you know, headlines are sensationalized, and they are attention grabbing, and you have to be aware not to just look at what is being put out there, but see what is really behind that. Okay, so what really is behind the headlines? So let's look at the hematopoietic stem cell transplantation headlines. All right, there have been several studies talking about the effectiveness of hematopoietic stem cell in MS patients. And I highlighted two of them here. And when you look at them, those studies, they, as I said, they have about 25, 10, or 20, and they're all phase 2 studies. So those studies are really just if phase 1 and phase 2. Phase 1, you're looking to see if it's safe. If it's safe. In phase 2, you're looking at efficacy on several measures. Phase 3 is when it's introduced to a broader population, usually hundreds of thousands of people. But phase 1, it starts with 10 or 20. Phase 2, you're like 50. So HALT MS trial was a trial with 25 patients, and the results were published at 2016 or 2017. And 69% of patients were free of disease activity within 5 years. That is very impressive, right? You know, and that's the goal of MS therapy. We have to say, you know, we don't want disease progression. We want to stabilize. We don't want any significant changes over an extended period of time. And when you look at this, 69% of patients stable or free of disease activity over 5 years. That is a great thing. But look at 7 patients failed treatment, and there were severe side effects in almost all of the patients. But this study is important. It's very important because it gives us an idea of where stem cell could go. It shows us the potential for stem cell use in MS, because even with 25 patients, we have seen that we have good treatment response in patients. The 7 patients that failed therapy, it tells us that this kind of treatment is not a cure. And that's important. This is looking beyond the headlines, right? Miracle, cure. It's not a cure. It's still a treatment. But it's important because we can move in a direction that is very good for MS patients. Say, look, we have a treatment that we need to further along in the process, that we need to refine and then be able to offer it to our patients. The second study I put here was an observational study. So when all of these little studies started to come out and say, look, we are seeing changes in our patients, researchers from around the world said, okay, for those of you who have had patients who have received stem cell, let's look at the data and see what the overall theme is. So that's why you see a huge number of patients. Once again, these weren't, you know, randomized, placebo control, which is what we would like to see all our medications go through to say this is very effective. These were patients who were given stem cell, hematopoietic stem cell therapy because they felt something and they didn't have any other options, or their doctor offered, they had very aggressive disease, and they say, here's an option for you. So this is something we have to take into consideration. These weren't controlled trials. They were just patients that received the treatment because their provider thought they needed it. So 281 patients across the world and mainly they look at patients almost over a 5 to 7 year time frame. And putting all those patients together, 46% of them remain free of disease progression over 5 years. So that is also a good result. There were 8 deaths between all of this. But I put it on here to say this was an observational studies, and the patients in these studies were mainly progressive patients, patients who had tried numerous drugs, and this was almost like a last resort drug for them, a treatment, for them. And at that time, there wasn't a defined protocol. So this was between, as I said, early 2000s to late 2000s, and now we're in 2008. But putting all of that together, even at that time, where we had patients who were had no other options, for some, or were progressive, or had high disability scores, we saw improvement in a good number of patients. All of this is giving us more information. This is something we need to follow up on, because patients are responding to it. We need to find the right patient. We need to find the right dose. We need to make sure it's safe and tolerable and offer it to our patients. So that's behind the headlines for hematopoietic stem cell. Now let's look at mesenchymal stem cell transplant. So this one is newer. It's a newer type of transplant that has been ongoing. Most of the data that we see is in animal studies, in mice. Okay, very effective in mice, but we have to be, I always tell my patients, once again, when you see that headline, is it in humans or is it in mice? Remember, we don't have tails, right? Okay, we don't wag our tails. So not everything that is effective in mice or animals is effective in humans. You know, there are lots of therapy, you know, that we see the effect in mice, and when we try to translate it to the human experience, they fail. So very few therapy, 5 to 10 at the most, get through that make that jump from mice to humans. But seeing it in animals and seeing the response that the mice had, we said, okay, let's see how it works in humans. And published recently phase 1 study. So once again, phase 1 study is to see the safety of a treatment. So 20 patients was in the phase 1 study, and basically the safety, mild to moderate side effect, very different from the severe side effect we saw in the hematopoietic stem cell with the chemotherapy, mild to moderate. And now they're looking at phase 2. Phase 2, we're looking at different measures on MRI, on different MS measures, especially MRI, to see if they are effective. So phase 2 studies are being planned for both relapsing patients and progressive patients, and it should be, we just had our big MS conference about 2 weeks ago, and they should start recruiting soon for that. But mainly for mesenchymal stem cell, mainly animal studies, is just making this jump into the human world. And it has the potential to be a safe treatment for patients. And we're looking at it in all forms of MS, so relapsing and progressive forms of MS. So if you're interested in stem cell therapy, what do you do? There isn't a week that doesn't go by that I don't have a patient asking me about stem cell. And we get bombarded in the news, you know, stem cell for this, stem cell for that. But we have to remember it's still experimental, it's not FDA approved, and there are still kinks to work out to get it to the real world. Real world, okay, not the experimental world. So it's good to be an informed patient. You have to be an informed patient. Patients always say, Dr. Okai, when I recommend something, I like to go and do my research. And I said, okay, you can go to Google and you can go to WebMD, but remember that they are not doctors. WebMD has an MD behind it, but he's still not a doctor. So use the internet for information, but don't use it as a decision-making tool. Go to an expert and ask the right question. Get what you need, write your question down, and go to a reliable source. It can be your physician and say, this is what I read. What do you think? Does it make sense? Is this the right way to go? So be an informed patient. ask the right questions and ask as many questions as you can, because if your questions aren't answered in a satisfactory manner or in an informed manner, then that should raise red flags for you. Be aware of studies that only give patient testimonials and not data. Okay, so if it's only about, well, we have this one patient here that did very well on our therapy, or this one patient here that did very well, be aware of that versus we have data and we're reporting on both the good and the bad. This is the success rate that we have seen. This is the failure rate that we have seen. This is the side effect that we have seen. This is the common one. These are the uncommon ones. So be aware of where you're getting your information from as well. Ask for scientific data regarding a specific treatment. If it's a clinical trial that's being offered, make sure that it's FDA regulated. The FDA, every trial that is done in the US is listed on clinicaltrial.gov. That's how you know that it's a trial that has been approved by the FDA. There's an oversight. They have an ethics committee, they have a safety committee, and they have to report in interim intervals to the FDA. This is what we're doing. This is what we're seeing. And this is to protect patients' right, and make sure that, one, you're not being taken advantage of, two, that safety is key, as well as the efficacy of the medication. Once again, look beyond the headlines. You know, when you see it, is it mainly animals or is it human study? All right, so that's something to also keep in mind. Questions to ask. I started this on the prior slide, but I'll go through that again. You know, what kind of stem cell are being used? Is it hematopoietic? Is it mesenchymal? Is it embryonic? Is it something else? What are the source? Where are they getting the stem cell from? Is it coming from you as a patient? That's important. Or is it coming from somewhere else or someone else where the risk of rejection can be higher and can cause all kinds of reaction? Think about it as a blood product. You know, you want to get a compatible blood infusion and not something that's incompatible. So what kind of stem cells are being used? Are you going to use your own stem cell, or is it going to be from someone else? Where are the cells being injected? Because we talk about, if the cell does not have the right signal, where is it going to go? It has to have the right signal. You don't want to inject in the lymph node and it just sits there and your lymph node gets big, or in your spine and it just sits there and it just forms a big mass. You want to make sure that it has the right signal to go where it needs to be. So where is it being injected? What are the benefit and the risk associated with that particular treatment that's been offered to you? All right, I give you just an overview, but there are in-depth, and you should have all of that information to start. Ask question, ask a whole lot of question. Is there published data to support what is being done? All right, is it, oh, we think this may be it, so let's do it, or we tried it in this one person and it's worked, let's do it. What is the data? Did it start in a small study? Did we see good results? Did we see bad results? What was it that led us to do this other treatment? So published data is important. It's going to help you. How is follow-up conducted? If you do go and get therapy, who do you call? What is being followed up? Safety, because safety is important, right? In case of emergency, who do you contact? What treatment are you going to take afterwards, if you need further treatment afterwards? One thing I forgot to mention with the hematopoietic stem cell study, when I said patients were free of disease progression over 5+ years, they did not need any further therapy at that time. Is there a safety monitoring process? Okay, so are they only going to inject you and say, you're done? bye-bye or come back when you feel something who was safety, because once again, for every reaction, there's an opposite reaction. So we have to look and see, okay, if it's efficacious, what are the safety concerns, if any, and how is that going to be followed? Okay, what benefit are you going to see? So if someone's going to propose stem cell, and all of this should be realistic, right? We have to look for realistic response, realistic treatment outcomes. All right, so I mentioned that these therapies aren't cure. They are for stability and long-term stability. So are you gonna, for someone who's in a wheelchair, realistically, what do you expect to see? Are you gonna get up from your wheelchair, which most people don't experience, or are you just gonna have stability? How long will it take for you to see the benefits, and how long will the benefit last? All right, so is it going to last 2 years? Is it going to last 6 months? Is it going to last 5 years? The probability of it lasting those times are what is important. And then you query whoever is giving you the treatment or the clinic. How many people in your clinic have gotten better? How many have not gotten better? What is the follow-up treatment? Who does the follow-up? What is the doctor's specialization? All right, do you want a plastic surgeon doing your stem cell treatment, or do you want a hematologist doing that? So it's important to know who's behind that, who's doing the treatment. Once again, questions will get you the answer and raise any red flags if there are any before you proceed to this. Most people say, well, Dr. Okai, what do I have to lose if I go through this? I have MS, and MS is bad as it is already. What do I have to lose? Well, you have a whole lot to lose if you don't ask the right questions, if you don't have the right safety measures in place. Long or short-term impact on your health. So short-term infection is key. Remember, I talk about all those points where introducing something into your body can be infected, or your immune system is low, or where it's coming from. That's one thing that can occur. Long term, if cells are put in your body and they don't go where they need to go, do they become a tumor? Just sits there, start pressing on other things. So short and long-term impact. For certain types of transplant treatment, when you have it, then that takes you out of the running for some other therapies that may come out. And there we have therapies on the market to say, well, if you have used this drug before, we don't recommend you taking this other drug. So it can have an impact, short and long term, on your health. Adverse reactions, allergic reaction can occur. Even though you may have cells that are taken from your body and being reintroduced into your body, that doesn't always mean it's safe. There could be adverse reaction with that as well. And if it's coming from someone else, that's even a higher risk of allergic or adverse reaction too. Financial, if you're doing medical tourism, as you call it, because we have limited studies in the U.S. Some people tend to go out of the country. In addition to asking all those questions about what's out there, how they're doing, it can also be very expensive. And so you have to weigh the financial impact on you and what you expect to get out of the treatment. Is the cost worth what you're going to get from that? So cost of therapy, paying out of pocket, travel, lodging, all of that comes into play when you're considering going out of the country for stem cell therapy. So information is important. Safety about the facility, about the procedure is important. Financially is important, and the impact on your health long and short term is also important. All of that have to be addressed while making this decision to undergo stem cell therapy. So what do we know so far? And I'm coming to the end of this lecture. We have small studies that have shown effectiveness in MS patients. So we know stem cell is a way to go to reduce the burden of MS, to slow down disability and provide long-term stability to our MS patients. We have to choose the right patient profile. So far for the hematopoietic stem cell, what they have found out that young age is a good patient profile. Relapsing MS, so if there's inflammation, either clinically or on the MRI, those patients are good candidates for the therapy. Low disability scores, so patients, we grade our neurological exam by mobility. So patients who are using cane, using a walker, or in a wheelchair, we classify them as higher disability scores versus patients who do not use an assisted device to walk. They have lower disability scores. So low disability score, also good candidate right now for what we have going on. And then short disease duration. So if you've had the disease for less than 10 years, people have a better response to hematopoietic stem cell therapy. But remember, I showed you the observational studies, and I said those patients were mainly progressive patients, and those studies were done a little bit earlier on. So we are designing studies for progressive patients because we feel that there is a role for stem cell in these patients. Once again, it's just finding the right dose, the right amount of cell, the right amount of chemotherapy, high or low, that we have to give for these progressive patients. Because while we got a whole lot of information from the earlier studies, that information still needs to be refined and adapted to all forms. But we know that the therapy worked in progressive patients. We just have to refine it. Okay? So to summarize, stem cell is still experimental. It's not an approved FDA treatment. It's not a cure, but it's another treatment option. And it holds great promise for MS patients, holds great promise. Every study that we see coming out, even in small numbers, points towards this being a great treatment options for MS and changing how we look at MS and how the face of MS patients looking into the future seem to them. And is capable of providing long-term stability for patients, and in some patients, some improvement. Okay? We're not saying it's going to improve everything, but it's capable of providing some improvement in disability in certain patients. Once again, we still need more studies to refine the safety, the efficacy, as well as the optimal dosing. So look at stem cell as another treatment option. Some people, when I recommend therapy for them, they're like, how long has that therapy been out, Dr. Okai? How many people do you have on that therapy? Look at it as another treatment option. Ask the right question. Sometimes it's hard to separate what we know logically from what emotionally affects us, especially if you're living with MS and you're having symptoms and you're saying, well, why can't I try this? But it's also essential that you look at the long-term impact as well. So it's not ready for prime time, but it's a very, very promising option for our patients. And most studies are being designed. Researchers have realized that this is something that we need to pursue, you know, they're putting more research dollars into this to get this going. And with that, I will stop here. All right, thank you guys. Thanks for braving the weather and traffic to come out here. Hopefully you got something out of it. One thing I can say, just be an informed patient and ask questions, ask questions, ask questions.